Good afternoon, everybody. My name is Dr. Mahesh Kumar, Associate Professor from Department of Oral Medicine, Radiology. Today, my topic will be on oral submucous fibrosis. Okay, what is oral submucous fibrosis? It was defined by Pinborg in 1966 that it's an insidious chronic disease affecting any part of the oral cavity, sometimes pharynx, although it can be associated with vesicle formation, always associated with juxtaepithelial inflammatory reaction followed by fibroelastic cartilage changes in the lamina propria with epithelial atrophy leading to stiffness of mucosa causing trismus and inability to eat. What is the epidermology? The disease predominantly seen in India, Bangladesh, Sri Lanka, Pakistan, Taiwan, and Indonesia. In India, 2 million cases in 1993, but now, according to WHO, it has exceeded 1.5 million annually by 2020. The major etiology for oral submucous fibrosis is chewing of areca nut or derivatives such as gutka, pan, masala, mawa, betel quid, supari and other formulations. The areca nut, which is the main culprit, which contains arecolin, arecadin, arecolidin, etc. are the main reason for submucous fibrosis. And the flavonoid components, which mostly is the tannins and the catechins. The other contributing factors for etiology of oral submucous fibrosis is chewing, smokeless tobacco, because of nutritional deficiency, chilies, toxic level of copper, genetic predisposition and immunological predisposition. The pathology, first we will talk about collagen, which is the main component which is involved in oral submucous fibrosis. The collagen is a natural protein that provides our body with structural support. Colla means glue or glue producing tissues. It's a triple helix structure which contains more than 21 types. In oral epithelium, the most common collagen is type 4 and type 7. And let us see about the synthesis or formation of collagen, which has 5 steps, which is pre-pro-collagen, pro-alpha collagen, pro-collagen, tropocollagen and collagen, which needs vitamin C, copper and lysol oxidase for the formation of collagen, whereas the enzyme like collagenase and gelatinase helps in degradation of the collagen. The basic pathogenesis behind oral submucous fibrosis is in the oral mucosa. The patient has a habit of chewing betel quid. The oral mucosa has increased susceptibility due to deficiency of iron and vitamin B12. This oral submucous fibrosis depends upon the duration and frequency of the habit. Once the quid is placed, there will be constant irritation in the oral mucosa, which leads to inflammatory cells, activated T cells and macrophages at the site of irritation. Basically, there will be increase in cytokines, interleukin 6, tumor necrosis factor, interferons alpha, and there is increase in the growth factor, transforming growth factor beta as well as transforming growth factor alpha, which is the main culprit in this oral submucous fibrosis. The overall effect will be there will be increased collagen production as well as there will be decreased collagen degradation. So what happens is increased collagen production is because of increasing the activity of the enzyme lysol oxidase, which again and again increases the formation of collagen, whereas this collagenase is an enzyme which helps in degradation of the collagen. So what happens here, this transforming growth factor beta will decrease the activity of collagenase, thus decreasing the activity of collagen degradation, leading to increased deposition of collagen. So what happens because of this increased collagen, which is in an insoluble form, leading to cross-linking of insoluble collagen and finally leading to fibrosis and oral submucous fibrosis. Okay, now we move on to the clinical features of oral submucous fibrosis, extraorally and intraorally. Extraorally, in the early stage, there won't be any significant changes, whereas in the moderate stage, there will be prominent masseter muscle because of over chewing, and there will be shrunken cheeks and thinning of lips and loss of nasolabial fold. There will be a prominent antegonial notch. In the advanced stage, there will be hoarseness of voice, atrophy of the facial musculature, fibrous ankylosis of the temporomandibular joints. Intraorally, in the early stages, there will be excessive salivation, burning sensation, blanching of oral mucosa, blister formation, presence of thin palpable fibrous bands, hypo or hyperpigmentation will be seen. In the moderate stage, there will be xerostomia, loss of taste sensation, decrease in mouth opening, difficulty in blowing of cheeks, blanching of the oral mucosa, and finally there will be presence of thick fibrous bands. In the advanced stage, there will be loss of suppleness of mucosa, mottled or opaque marble-like appearance of the oral mucosa, depapillation of tongue, shrunken uvula with already hockey-shaped or bud-shaped, and involvement of the pharyngeal or esophageal mucosa. There are hundreds of grading in oral submucous fibrosis, but the common grading that we use is Gupta et al. Classification, which helps to clinically grade the submucous fibrosis. Grade 1, there will be blanching of mucosa and small vesicle formations. In grade 2, there will be burning sensation, dryness of mouth, vesicles or ulceration without any tongue involvement. Grade 3, there will be difficulty in mouth opening, that is mouth opening will be reduced less than 40 mm in size, and in grade 4 there will be palpable bands all over the mucosa except the tongue involvement. In grade 5 there will be tongue involvement, and finally in grade stage there will be histologically proven malignancy. So what is the reason for malignant transformation in OSMF? It is first described by Paymaster and Pinbog et al. Substantiated the malignant potential of submucous fibrosis due to 5 main criteria. First is the high frequency of OSMF in patients with oral cancer, increased prevalence of oral squamous cell carcinoma in patients with OSMF, histological diagnosis of squamous cell carcinoma in patients without any obvious tumor in OSMF, high frequency of epithelial dysplasia, and a higher incidence of leukoplakia among oral submucous fibrosis patients. People with OSMF are 19.1 times more likely to develop oral cancer than the normal person. The mean age of presentation was 44.5 years, and 76% of the cases were male because of increased habit. Okay, now how we are going to manage this oral submucous fibrosis? Initially, we have the preventive measures, that is the patient should stop the habit from the day 1 he goes for treatment, and second, that is medical management, physical therapy, and finally surgery that can be done using laser or normal scalpel. Preventive measure, you should advise the patient to go for habit counseling, and in medical management you have topical, intralesional, and systemic. In topical, there is application of betamethasone or triamcinolone acetonide 0.1%. In case of intralesional injections, we give chymotrypsin, interferon gamma, hydrocortisone, betamethasone, methylprednisolone, triamcinolone acetonide, and dexamethasone. Systemically, we prefer levamisole, immune milk, and colchicine. Benzodiazepine 0.15% mouth grease is commonly used, that is called as Stanton mouthwash. Triamcinolone acetonide gel 0.1% is used. Swish and split method of prednisolone, that is 5 mg is commonly used. Then we can go for oxytad capsules, vitamin A capsule, lycopene, which is an extract from tomato, which has a very good antioxidant property, and finally vitamin B complexes. And in case sometimes we go for pentoxifylline 400 mg, but this has been recently banned because of its side effects, and lactoferrin immunomodulator derived from bovine milk. Intralesionally, we go for steroids, that is 4 mg per ml of dexamethasone or betamethasone diluted in 1 ml of 2% xylocaine. Biweekly injection for 6 months. Then you go for hyaluronidase, which is an extract from Streptococcus bacteria. 6 weeks course of intralesional injection of 4 mg dexamethasone and 1500 units of hyaluronidase twice weekly that helps in management of oral submucous fibrosis. And we can use placental extracts, hyaluronidase, colchicine, and intralesional interferon gamma. In oral physiotherapy, we use muscle stretching exercise for the mouth, including forceful mouth opening with the help of sticks, ballooning of mouth, and hot water gargling. Forceful mouth opening have been tried with mouth guard and acrylic surgical screws. Physiotherapy can improve oral opening but not affect the pain. So normally use a dynamic screw with flanges, or a simpler screw with flanges, or a static wooden peg with serrations, and finally a similar bigger wooden peg in a fully open mouth. Naturally, there are certain measures that helps in oral submucous fibrosis. curcuma, that is turmeric, then use this tea pigments, aloe vera and spirulina. These are the common naturally occurring products that helps in the treatment of oral submucous fibrosis. Then we go for hyperbaric oxygen therapy, then therapeutic ultrasound can be given, and finally surgery using laser or excision of the lesion and constructed with split skin graft. Thank you.